Thanks the Charing Cross and an opportunity for me to present my paper on endovascular stent graft for aortic aneurysmal disease in large vessel systemic vasculitis. I, Dr. Rajesh Vijayvargi, doesn't have any conflict of interest regarding this presentation. Large vessel vasculitis constitute Takayasu Arteritis, Giant Cell Arteritis, Behcet's disease, and Cogan syndrome. It can present with aneurysmal dilatation of aorta and its major branches. As the disease is systemic, there can be multiple disease sites, the management of which is challenging and troublesome. Endovascular repair can be an alternative to standard open surgical repair in selected patients. My case first is about a 52-year-old hypertensive female, a diagnosed case of Takayasu aorta arteritis from last 24 years with total occlusion on left common carotid, left subclavian and right renal artery since 1994. She was on the steroid maintenance therapy and in January 2019 presented with a pain chest radiating to the back and was found to have a two saccular aneurysm in the lower part of the descending thoracic aorta, each measuring more than 6 centimeters in the size. She was taken for the TVAR and a 26 × 134 mm graft stent was deployed across the descending thoracic aorta to exclude both the aneurysm. She is doing well at 2 years of follow-up. Another case, a 24-year-old boy presented with hypertensive encephalopathy in January 2014, had a disparity in the blood pressure upper and lower limb. CT scan did found diseased 3 arch vessels with multiple saccular aneurysm of descending thoracic aorta. Largest one was of 44 mm in the size. PET showed the disease activity for which he was put on steroid and 4 antihypertensive drugs. For next 4 years, he remained relatively asymptomatic on maintenance steroid therapy and antihypertensive, and thereafter he presented with uncontrolled hypertension and the back pain, for which a CT angiogram did show a 5.6 centimeter size descending thoracic aneurysm with the impending rupture. He was taken for emergency TVAR and a 34 × 100 mm variant stent was put to exclude the aneurysm. He had a 3 year of asymptomatic clinical follow-up. Another case, a 59-year-old hypertensive male presented with a pain left iliac fossa of 10 days duration in October 2017 and was found to have a bilateral common iliac aneurysm with the left common iliac aneurysm got ruptured associated with a surrounding hematoma of 17 × 10 centimeter. He was taken for the emergency endograft repair and the left common iliac was covered with two overlapping graft stent. He had on evaluation were found to have raised ESR and C-reactive protein. PET-CT showed the increased uptake of the bilateral iliac arteries, was diagnosed to have extracranial giant cell arteritis, was treated with a steroid and cyclophosphamide. He is doing well at 3.5 year of follow-up. The last case, a 45-year-old HLA-B08 positive female, had a history of recurrent painful oral and genital ulcer from last 12 years, also had one episode of right eye panuveitis, diagnosed with Behcet's disease and was started on steroid. In June 2018, she presented with acute pain abdomen 10 days duration. Ultrasound did show a aneurysm which was confirmed with a CT angiogram which showed a large 5.8 centimeter size aneurysm with the rupture and surrounding big hematoma. She was taken for emergency EVAR and a 20 × 82 mm endurant Medtronic graft stent was deployed. She had an asymptomatic 2.5 years of follow-up. So in conclusion, systemic vasculitis is an uncommon cause of thoracoabdominal aneurysm. Medical treatment include control of disease activity by steroid and immunosuppressive therapy. Endovascular intervention is an alternative option in selected patients. It's a safe and effective in the emergency situation, like we had 3 out of the 4 cases who had an impending or ruptured aneurysm and were successfully treated. Thanks for the kind attention.